Thank you very much for the opportunity to speak today on Ivabradine, when all else fails or before anything else. No disclosures. I'll be reviewing first the mechanism of action and pharmacology of Ivabradine. Next, I'll review the current evidence for its role as an antiarrhythmic, specifically with regard to post-hoc jet, PAT, and congenital jet. Then I'll address the question of whether it should be used before anything else, meaning as a first-line agent, or when all else fails, in other words, as a last resort. To this point, we'll review the existing safety data, especially with regard to use of concomitant antiarrhythmic agents. First, we'll review the mechanism of action of Ivabradine. Ivabradine is a novel heart rate reducing agent. It acts by blocking HCM-gated transmembrane sodium channels, thereby selectively inhibiting the funny current. This reduces the slope of phase 4 of the action potential, which results in reduced tissue automaticity. Ivabradine was initially FDA approved in 2015 to reduce hospitalizations in adults with stable heart failure by lowering their sinus rate. Then received pediatric approval in 2019 for the specific indication of dilated cardiomyopathy in patients greater than 6 months. This demonstrated a promising role in the treatment of arrhythmias due to increased automaticity, as HCM channels are primarily localized in pacemaker cells and may be upregulated in areas of abnormal automaticity. The agent demonstrates a property of use dependence, which means it has an increased effect at higher heart rates. It has a hemodynamically neutral profile with no effect on cardiac contractility, repolarization, or blood pressure at standard doses, and therefore is an attractive, pure heart rate lowering agent. Ivabradine has similar PK and PD properties in children as seen in adults. It is hepatically metabolized and renally excreted. There's a growing body of literature demonstrating efficacy of Ivabradine for arrhythmias, and we'll review each of these today. First, we'll talk about post-operative jet. There's several recently published case series and case reports on the efficacy of Ivabradine for post-op jet. I'd first like to highlight this study by Krishna et al. From 2019. This was a case series of 8 patients ranging in age from 3 days to 5 years with post-operative jet. Ivabradine was dosed at 0.05 mg per kg per dose, Q12 hours. They found that they achieved rate control in 8 out of 8 patients with a response in less than 2 hours in 7 out of 8 patients. In 75% of patients, Ivabradine was used as monotherapy for treatment of post-operative jet. There were no adverse events in these 8 patients. So they concluded that Ivabradine is a safe and effective alternative to amiodarone in post-operative jet, and recommended that early initiation of Ivabradine, as soon as junctional rhythm is identified, may allow for rhythm control before the onset of a faster, hemodynamically unstable jet. This was a single center study with a small n and a relatively slow jet rate. The next study to mention was a very exciting study published by Arvind et al. In 2021. This was a randomized, open-label, controlled trial comparing amiodarone to Ivabradine for post-operative jet. 94 patients were enrolled at a single center. In the amiodarone treatment group, patients received a 10 mic per kilo per minute infusion for 6 hours, followed by a 5 mic per kilo per minute infusion. I note that they did not receive a bolus of amiodarone. The Ivabradine treatment group received a dose of 0.1 mg per kg per dose enterally every 12 hours. I note that this is twice the dose used in the previous case series. The primary endpoint was restoration of sinus rhythm. However, several additional secondary endpoints were evaluated, including time to rate control, time to sinus rhythm, and drug-related adverse events. There were no significant differences between the 2 treatment groups in terms of baseline characteristics. Highlighted here is that the mean age of this jet cohort was a bit older, with a mean age of about 3 years old. This was also a later onset of JET around 40 hours after surgery. In terms of the primary outcome, they found similar rates of conversion to sinus rhythm, 96% for Ivabradine versus 94% for amiodarone. In terms of secondary outcomes, there were no drug-related adverse events in the Ivabradine group. In terms of other secondary outcomes, they did observe a shorter time to rate control in the amiodarone group, 7 hours versus 8 hours. These graphs visually demonstrate the shorter time to rate control in the amiodarone group. So Arvind et al. Concluded that oral Ivabradine is not inferior to IV amiodarone in converting JET to sinus rhythm. And they concluded that it appears to be safe with no drug-related adverse events. And they recommended that monotherapy with Ivabradine may be considered as an alternative to amio in the management of postoperative JET. Now, some limitations of this study to mention. One is that the primary endpoint of time to sinus rhythm may be confounded by the potential for spontaneous JET resolution. And so time to rate control may be the more clinically relevant variable to evaluate for treatment of JET. And this also brings up the fact that there was no amiodarone bolus in the amiodarone study group. As a result of the protocol, the patients received 3.6 milligrams per kilogram of amio over the first 6 hours of the study, in contrast to what is an often a standardly used dose of 5 mg per kg of IV amio as a bolus over the first hour. And so this absence of bolus dosing may have also affected time to rate control for this study. Another thing to mention is that this is an older cohort with postoperative JET, median age of about 3 years old. And so extrapolation to the management of neonates and infants with JET may not be valid. Next, I'm going to discuss what we've learned about Ivabradine from our PACES Multicenter Registry. To review, this is an ongoing multicenter prospective registry collecting observational data on clinically used Ivabradine and the outcomes of that treatment. Any tachyarrhythmia treated with Ivabradine is eligible for inclusion. This includes both acute postoperative arrhythmias and non-postoperative arrhythmias. The primary outcome is Ivabradine-related adverse events, and secondary outcomes include efficacy, which is graded as either complete or partial rhythm or rate control. And a positive response to Ivabradine is defined by at least partial control. As of September of 2022, 63 subjects from 6 centers have data entered into the registry. This includes 14 patients with postoperative JET. In terms of the characteristics of this JET cohort, about 2/3 are less than 6 months old. So this is a younger cohort than studied by Arvind et al. About 2/3 are receiving concurrent amiodarone, and a significant majority, 86%, are also receiving Precedix. The Ivabradine dose initiation, the median dose was 0.05 mg per kg per dose, so similar to the first case series and a smaller dose than used in the Arvind et al. Trial. So far, we've observed a positive response in 71% of cases, with effective rhythm control in 43% and effective rate control in 21%. The median number of doses to the first sign of an effective Ivabradine is 2. The effective dose was reported to be a median of 0.1 mg per kg per dose, which is the dose used in the Arvind's trial. Here's an example of postoperative JET treated with Ivabradine from our center. This was a patient who was struggling after a complex biventricular repair, had already received about 10 mg per kg in IV amiodarone boluses, and was on an Esmol infusion with ongoing JET, and the Esmol was limited by hypotension. So the patient was given a first dose of 0.02 mg per kg of Ivabradine. This was a patient was less than 6 months, so the initial dose was small. There was initial response about 90 minutes later with a brief period of sinus rhythm. However, JET then resurged, so The dose was repeated a few hours later, 0.25 mg per kg. And about 90 minutes after this dose, the junction rhythm had slowed such that atrial pacing was then instituted. So this example showed a nice response to post-op jet, nice response to Ivabradine and post-op jet that had been refractory to high doses of amiodarone. There's some limitations to highlight from the registry data. Notably, this is observational data. There's center variability in patient selection, Ivabradine dosing, and the use of additional antiarrhythmic agents. And the efficacy grading is somewhat subjective. So to summarize the data so far on Ivabradine and post-op jet, should it be used when all else fails or before anything else? So in terms of using it as a first-line agent, you should consider Ivabradine for early jet, try to preempt the need for amiodarone, as we know that amiodarone IV is not without risk. And this using Ivabradine early is supported by the Krishna and Arvind studies. Should be used when all else fails. Well, I think that Ivabradine can be very useful for medically refractory jet, especially when you're trying to ward off ECMO. And this is supported by cases from our cases registry. Next, we'll discuss ectopic atrial tachycardia. This table summarizes a few case reports and case series on the use of Ivabradine for EAT. In terms of the EAT cases in the Ivabradine registry, so far we have 35 cases. 10 are acute postoperative EATs. 25 are EATs that are not occurring in the acute postoperative setting. Looking at the 10 postoperative EATs, about 40% were also on amiodarone, 50% on Janson, 50% on beta blocker, and about 30% on Precedex. We observed positive response in 70% with a median dose to first effect of 2. And the effective dose was 0.05 mg per kg per dose. In terms of the non-postoperative EATs, there was a positive response in 60% with a median number of doses of 1 to the first sign of an effect, and an effective dose also of 0.05 mg per kg per dose. Here's an example of a non-postoperative EAT successfully treated with Ivabradine. Panel A shows the 12-lead EKG showing an EAT with variable AV block. And then panel B shows time 0, again, EAT, and by time 1 hour and 25 minutes after the first dose of Ivabradine, there's a sinus rhythm with frequent PACs, and then a few minutes later, there's consistent sinus rhythm. And so this was a nice and very quick response of an EAT to oral Ivabradine monotherapy. This is another study showing efficacy of Ivabradine for atrial tachycardia. This was a prospective single-center study. 28 patients with incessant atrial tachycardias were enrolled. The mean age of this study cohort was 35 years. There were 7 pediatric patients included, ranging from 1 month to 17 years old. Mean tachycardia rate was 170. None of these patients had congenital heart disease. About half had previously failed beta blocker. Small percentage had failed IV amiodarone. They developed a protocol to give Ivabradine monotherapy to these cases. The dosing for adults was 10 milligrams PO212. Note that this is a higher dose than is the published recommended dose. The published recommended max dose is 7.5 milligrams Q12 for adults. They used this as sort of an acute loading dose, and patients who responded, they had on a lower maintenance dose. For the children less than 50 kilos, they used a dose of 0.14 mg per kg per dose, also a bit higher than what has been used in some of the other studies. What they found was that there was a 64% positive response to Ivabradine, so 18 out of 28 patients. Rhythm control was achieved in 17 and rate control in 1, with a mean time to tachycardia termination of 4.3 hours. For patients who were continued on Ivabradine, there was no recurrence over a follow-up of about 5 months. They observed no drug-related adverse effects. When they compared Ivabradine responders to Ivabradine non-responders, the only predictor of a response to Ivabradine was an atrial appendage origin. So about half of the atrial appendage origin tachycardias responded, and of non-responders, there were no atrial appendage, atrial tach. And this is just an example of a tachycardia. This is one of the teenagers in this study. And this, the panel A shows her EET, panel C shows sinus rhythm, and this is the cardome map. So from this study, the authors concluded that a trial of Ivabradine should be considered in all patients with incessant focal atrial tachycardia and structurally normal hearts. And they published an algorithm to consider treating these patients, including dosing. And they recommended discontinuing Ivabradine if there's no response within 12 hours of initiation. So to summarize the data on Ivabradine and EAT, should it be used when all else fails or before anything else? So consider Ivabradine as primary therapy for an incessant AT, especially if the surface ECG is suggestive of an atrial appendage origin. This is supported by the Ben-Avalikar study. Also consider Ivabradine for EAT that's refractory to beta blocker. In other words, before escalating to flecainide or another class 1 or class 3 agent that may have a more significant side effect profile than Ivabradine. And should it be used when all else fails? We recommend considering Ivabradine to avoid or delay ablation in an EAT with associated tachycardia-induced cardiomyopathy. This is supported by some case reports in the literature. And consider Ivabradine as an adjunctive agent in drug refractory postoperative EAT. This is supported by the registry data so far. What do we know about Ivabradine and congenital jet? This table summarizes some case reports and case series on the efficacy and safety of Ivabradine for congenital jet. This paper by Dr. Deeks and Dr. Paul and Dr. Krause is one of the very first studies demonstrating Ivabradine use in arrhythmias in kids, and really, one of the inspirations for the current registry study. And they studied 5 patients with congenital jet, and the starting Ivabradine dose. These patients had failed conventional therapy. The starting Ivabradine dose was 0.05 to 0.1 mg per kg per day, divided Q12, and they found a mean effective dose of 0.22 mg per kg per day, which is 0.1 mg per kg per dose. They achieved rhythm control in 4 out of 5 and rate control in the 5th patient. And there were no adverse drug effects. This table summarizes the characteristics of these patients, and note that all were on significant or good doses of amiodarone in addition to Ivabradine, so it appeared safe in combination with amiodarone. And 3 patients also had ventricular dysfunction. So far in the registry, we have 3 patients with congenital jet, and so the data on its efficacy here is still early. So to summarize the data on Ivabradine and congenital jet, should we use it when all else fails or before anything else? So before anything else, for neonates with congenital jet in need of acute rate and rhythm control, consider starting with IV amio and then adding Ivabradine. In other words, consider it as your second-line agent after amiodarone. This is supported by the Deeks et al. Study. For older patients with congenital jet, consider Ivabradine monotherapy if they have beta blocker or other antiarrhythmic side effects. And when all else fails, case reports have demonstrated its efficacy and safety in combination therapy that can help avoid or delay ablation. So just a final comment on the safety profile of the agent. So far from our registry data, it appears safe. Only 1 of 63 patients have a documented medication-related adverse effect. This was a 15-year-old with repaired biventricular heart disease who had a non-postoperative junctional tachycardia. This patient developed pauses on Ivabradine and sotalol, prompting discontinuation of Ivabradine. Otherwise, there have been no drug-related adverse effects. The safety data was initially established by this study on Ivabradine in patients with dilated cardiomyopathy, and this is what led to the drug's FDA approval. In this study, 116 children with dilated cardiomyopathy were randomized to receive either Ivabradine or placebo. Note that majority of patients were on beta blocker and many were also on Janson. Symptomatic bradycardia occurred in 4% of Ivabradine subjects aged 1 to 3 and 5% of those 3 to 18 years old. Led to a dose reduction in only 1.6% of the Ivabradine group, and no patients had drug discontinuation due to symptomatic bradycardia. Otherwise, there were no cases of AV block, atrial fibrillation, or other arrhythmia in the Ivabradine group. And finally, this case report illustrates a word of caution. This was a case of an infant with an incessant EAT who had a very nice response to Ivabradine with effective rhythm control. However, while in the hospital, received a 10 times overdose due to inadequate administration. And this inadequate administration is related to the fact that the commercially available solution is a 1 mg per ml, a solution that comes in a 5 ml ampule. And so there can be confusion in how much to give the infant. So this patient experienced a heart rate nadir of 50, which was sinus bradycardia, 4 hours after the dose. Other than discontinuing antiarrhythmic agents, including Ivabradine, the patient did not require any other hemodynamic support or any other intervention. So in this case is both a word of caution in terms of education of both parents and staff about the administration of this drug, and also potentially illustrative that there may be a plateau effect in terms of the drug's heart rate lowering, and there has been some animal data that suggests a potential plateau effect of the drug's effect on the funding current. So just to conclude with some practical suggestions, consider Ivabradine for early jet. Try and preempt the need for amiodarone, as amiodarone is not without risks. Consider Ivabradine when you're dealing with a medically refractory, hemodynamically significant post-op arrhythmia, and try to ward off ECMO. You can always start with a small dose and consider redosing early if there's an inadequate or unsustained response. You can also, although technically it's recommended to give at 12-hour intervals, we have dosed at 2 8-hour intervals, especially if we're starting with smaller doses. And in the postoperative setting, until we know more and have more experience with the drug, I think it's prudent to ensure a functional pacing wires, especially if AV conduction is not known to be intact. So just to summarize, should you use Ivabradine when all else fails? Yes, I think when you're dealing with a drug refractory, hemodynamically significant tachycardia, I think it can be used safely in combination with other antiarrhythmic drugs, most notably the beta blocker and amiodarone, which we've seen the most data on. And should it be used before anything else? I think sometimes, and this can be on a case-by-case basis. And future directions will hopefully better define which substrates are most likely to be Ivabradine sensitive. Hopefully we'll define optimal dosing for Ivabradine, as I think some non-responders may be due to underdosing. And hope to see more prospective trials for postoperative JET comparing Ivabradine to other standards of care, whether in isolation or as an adjunctive agent. And finally, I think there's a need for IV formulation of Ivabradine, as some of the limitations of the drug relate to poor absorption in the postoperative or critically ill setting. Thank you very much.